Well, good morning and welcome everyone to the Department of Medicine ground rounds this nice chilly fall morning. We have three highly accomplished PGY3's chief residents who's going to talk to us this morning under the supervision of Dr. O'Shea. Our speaker are Zhou. Tina is a third-year internal medicine resident with interest in cardiology. Her research is focused on cardio-oncology and primary care management of heart failure. Our second speaker is Dr. Mohammad Jay. He's a third-year internal medicine resident with special interest in marginalized population health. He's volunteered in various communities, community initiatives advocating for marginalized population, such as refugee and ODPS clinics. He led a social accountability student advisory committee as a medical student, and he co-founded the Social Medicine Network for Ontario, an online platform aimed to connecting health care trainees and community organizers. He's involved in care of marginalized who are involved in the care of marginalized population. During his residency, he was the education lead for the Social Medicine Committee, and he's developed a curriculum around social determinants of health for the internal medicine residents and is organizing the first provincial social accountability research conference in healthcare. Our third speaker is Dr. Berditchevskaia, and Ina is a third-year internal medicine resident interested in general medicine and in shelter health. She holds an MSc in System Leadership and Innovation from the Institute of Health Policy, Management, and Evaluation. Her data collection work on death among people experiencing homelessness in Hamilton has been featured in news outlets including CBC Hamilton, The Spectator, and Global News Hamilton. And she is the past chair of the Internal Medicine Residency Program Social Medicine Committee. So three very, very impressive young residents who's going to talk to us about a very important topic to all of us in Hamilton and Ontario and Canada and actually globally. They're going to talk about the health, morbidity, and mortality among people experiencing homelessness. I'm sure you all will find it very, very useful. So I'll pass it on to Ina, and she'll take it from there.
Thank you so much for that lovely introduction, Dr. Azam. So my name's Ina, my colleagues here, Tina and Mo. So we, as Dr. Azam said, will be speaking about health, morbidity, and mortality amongst people experiencing homelessness. And this is in Hamilton and beyond. And we are supervised by Dr. Tim O'Shea, who has kindly joined us this morning. So what our goals here will be is to understand the effects of social determination of health, so really society's role on the development of homelessness, then to share some of the newest mortality data on people experiencing homelessness in Hamilton, and then to assess the current evidence on interventions to reduce mortality and morbidity among people experiencing homelessness. So we're going to start with a land acknowledgement. So as many of us have heard before, Hamilton Health Sciences is on the traditional territory shared between the Haudenosaunee confederacy and the Anishinabe nations, and that was acknowledged in the Dish with One Spoon Wampum Belt Treaty. Having said that, we didn't just want to stop there, given that there is a pretty big intersection between indigeneity and homelessness here in the city of Hamilton. The three of us are settlers ourselves, so we feel it's important to contend with uncomfortable truths about how Canada's history and its ongoing actions continue to oppress its Indigenous population. So going right back through history, right through to the doctrine of discovery, the Indian Act, 60s scoop, residential schools, and currently a child welfare system that disproportionately targets Indigenous families, a colonial legal system. So all of these things are kind of systemically designed to lead to a loss of land, language, and culture. There's not a lot of data on the proportion of Hamilton's population experiencing homelessness that is Indigenous, but what we know that while Indigenous people in Canada represent less than 5% of the population of the country, they do represent about 30% of the individuals and families experiencing homelessness nationwide. There was this urban Aboriginal survey in 2015 in Hamilton that surveyed 76 people, and we will see that that's a very small sample of people experiencing homelessness in Hamilton. But of the people they surveyed, about 47% were Indigenous. And a lot of those people you'll see in this yellow slice here are a part of the hidden homeless population. So people who were couch surfing and kind of out of view of potentially some of our data collection mechanisms. So based on these numbers, a lot of the systematic violence that continues to be carried out towards homeless individuals in Hamilton is carried out disproportionately towards Indigenous people. And if you'll recall the encampment teardowns, this was an Indigenous event that happened around that. So I will leave you with the words from an Indigenous group that published a commentary on the Hamilton Community Legal Clinic website. Since we do speak about the dish with one spoon wampum belt, this kind of, I think, speaks to it pretty well, that removing encampments without alternatives for those displaced is taking away the spoon. And when we take away the spoon, we are feeling privileged enough to interpret the treaty, which is dish with one spoon, in a manner that justifies our behaviors and accommodates only our needs and wants. This was not the intent of the Treaty on Indigenous Land. No one is privileged to interpret the treaty to benefit only them, and this includes elected officials such as mayors and council members, as well as policing agents who carry out their mandates. So we'll dive into the main body of the talk, but we're happy to circle back to this at the end if anyone has questions. So we'll speak first to Hamilton's homeless population, then we'll talk to the effects of social determination of health on housing, some of the challenges in healthcare access amongst people experiencing homelessness. Then we'll jump into a little bit of the mortality data in Hamilton and beyond. Then we'll speak to overdose, which we will find is the biggest killer, and some interventions there, and then some midstream and upstream interventions as well. So before we move forward, I think it's important for us to define homelessness, just so that everyone knows what we're talking about. And this is a definition we used in the study on mortality among people experiencing homelessness. It's modified from the Canadian definition on homelessness that was published by the Canadian Observatory on Homelessness. So it is the situation of an individual or family without stable, permanent, appropriate housing or the immediate prospect, means, or ability of acquiring it. So this includes both unsheltered homeless and sheltered homeless. This includes people who are sleeping rough outside or in temporary or unsafe accommodations, so things like encampments and tents, and also includes people accessing emergency shelters or couch surfing or in other short-term accommodation. Important to keep in mind that it also includes people who are staying both in our medical facilities and in our correctional facilities, but don't have a fixed address in the community. So what do we know about Hamilton's homeless population? So this is taken directly from the Housing and Homelessness Dashboard, which is a relatively new fixture of the city of Hamilton. It started up this past spring. And I want to draw your attention over here to the numbers of current individuals actively homeless in Hamilton. Again, this is probably an underestimate because of the hidden homeless population, but we know of about 1,500 individuals. And for those 1,500 individuals, there are only about 560 shelter beds. So I'll bring your attention over here to the shelter occupancy. So the green and blue lines are men, women, and family shelters, and you'll see that throughout the year, they're pretty well at 100% occupancy. This is just quickly to say that right now we know of more people who are kind of newly homeless or under 6 months than we know about who are homeless for over 6 months. And this will come back later on in the talk. I'll hand it over to Mo.
Next, I'll talk about the effect of social determination of health on housing. Next slide, please. From the perspective of social determination of health, homelessness is both a consequence and a contributor to adverse health outcomes. As you noticed, Ina and I use the word social determination of health as opposed to social determinant. And that's to suggest a more systemic contributor. Going through various studies, I found the quotes by Stafford and all interesting. The socially determined pathway to homelessness is neither simple nor linear, but often comprises a tangle of factors at the economic, housing, interpersonal, and individual level. To reduce the impact of homelessness on health, we need to first acknowledge the psychosocial issues, because treating the medical issues without addressing the social problem is almost certainly futile. Homelessness is a cumulative result of dysfunction in family, social, economic, and relational issues. And actually, studies from Scotland have shown that homelessness is often preceded by life adversities rooted in childhood. Individual experiences homelessness often have many competing priorities with chronic or acute health issues, such as how to get their next meal, where to sleep, how to maintain their safety, which can take precedence over seeking medical help. Next slide, please. So what are some challenges in healthcare accessing people experiencing homelessness, and what do we know about it? Next slide, please. We know that individuals experiencing homelessness are less likely to access preventative health services, which leads to increased late-stage prognosis, late-stage diagnosis of diseases, poor control of preventable diseases, and hospitalization for preventable conditions. Next slide, please. A study of 366 individuals in Toronto found that only 43% of them had a family doctor, and that odds of having a family doctor decreased with every additional year spent homeless. Next slide. Another study out of US showed that looking at homeless individuals experiencing homelessness found that they were predominantly male, they were less likely to have insurance, more likely to receive a psychiatric diagnosis when they went to emerge, and they were 4 times more likely to visit ER within 3 days of a prior ED visit or 1 week after a recent hospitalization. Next slide, please. So what are some factors associated with satisfaction? Study looking at 497 individuals experiencing homelessness in Quebec found that greater satisfaction was associated with having a family doctor and a case manager. And I think the reason for this is twofold. Number one, continuity of care. And number two is ease of access to specialized mental health and community services. Also, strong social network promoted satisfaction, so did common mental health disorders and substance use disorder. And the reason for that, suggested by authors, was these factors were associated with better access and support from mental health services, facilitating user satisfaction. In terms of lower satisfaction, frequent use of public ambulatory health services was associated with it. And there are a couple of possible explanations for this. Number one, frequent users of services are also those who may receive inadequate treatment or insufficient continuity of care, and that these individuals have more serious needs. Next slide, please. So what are some barriers? A study out of Calgary looked at 22 individuals and found barriers across patient, system, and provider domains. Specifically from a patient barrier perspective, emotional burden of having a new medical diagnosis, knowledge and priority of patients. So, in clinical encounters, we often ask our trainees what their objectives are. Similarly, patients' priority may be different than ours in a given encounter, and it's important to assess those priorities. In terms of systemic barriers, financial, is a barrier. An example of it is cost of taking a taxi or a bus to appointments. Other structural causes, such as missing or stolen ID. So, especially individuals outside of province or immigrants, that can be an issue. Provider barriers include geographic location, but also the attitude and discrimination. Next slide, please. I found this quote to be powerful from the study from one of the individuals experiencing homelessness. I ended up at the urgent care center. I went there and they said, no, you're really in trouble, your lungs. They admitted me to the hospital and the doctors said, I'm admitting you. He had all the papers. He comes back an hour later and says, what's your address? I said, the shelter. Then he says, well, just a minute. He went and comes back and said, I look at your vitals and now you're so much better compared to 5 hours ago. So I'm going to let you go. At 3 a.m, because I said I was staying at the shelter, I'm pretty sure.
Sorry. Now that we've spoken a little bit, and thanks for that really powerful quote, Mo, about people accessing healthcare while homeless, we're going to make a little bit of a jump to some of the mortality trends among people experiencing homelessness. And then we're going to, after that, take a step back and look more at morbidity. So first of all, who's collecting the data? So looking at Canada, the only municipality before we had started this project that is collecting the data was Toronto, and it's done through the Office of Public Health. The only province that publishes data on a provincial level is the BC Coroner's Office, and they have reports every 4 years or so, and they are just in the process of releasing their report right now for the past 4 years. There's also been research studies in municipalities in Montreal and Ottawa, and then there's homeless memorials in cities across the country, but no formal data collection or reporting. There's a lot more of a movement in the United States towards collecting this data, and that's led by, down here you see the national initiative that is the Homeless Mortality Toolkit. The Homeless Mortality Data Work Group is the one leading it. So I initially listed a bunch of the counties that collected their data, and there were far too many. It's usually the cities and counties that have the largest homeless population, and usually this is conducted by the medical examiner. There's only one statewide one, and that's in Maryland. So this is just pulled from that homeless mortality toolkit purely to highlight the average ages that we're seeing in a series of different counties across the United States. Really, people are dying in their 40s. And how is that reflected in Canadian data? This is pulled directly from the Toronto website. I put a QR code up if anyone's interested in looking at the dashboard that they have on the City of Toronto website. But I'll orient you a little bit to this graph because, as Tina helpfully pointed out to me, it looks almost like a normal distribution, which is not what it is at all. Each of these blocks speaks to an age range. And within that, we see over time the progression of that age range. So we are seeing that in the last 2 years, look at that uptick of people dying in their 20s and 30s. It really is truly alarming. And then that decrease that's happening in the other age groups. So as far as we know, the leading causes of death is drug toxicity. Almost half of the people that the City of Toronto knows about have died of drug toxicity, and about 20% of them have unknown causes of death, and about 10% of them have cardiovascular disease, and that's the next one down. There's really a big jump from that drug toxicity to the next leading cause of death. So we started up a project here in June of 2021. Initially, it was myself and Dr. Jill Wiltrick, who some of you may know. She has since moved away from the city, and the project group now consists of myself along with Dr. Claire Bodkin, who is a family doctor and a physician working in addictions, as well as Jesse Stearns, who is a Master of Social Work candidate and has a lot of experience working in groups for advocacy for people experiencing homelessness, and Dr. Jessica Scott, who's a PGY1 in our own program. So we have two major pillars as to how we're collecting this data. The first one is community reporting. So this mirrors what Toronto Public Health does. There's a secure form that we are disseminating to shelters and community agencies, and purely just asking their workers to fill it out when they learn of a death of one of their clients. So obviously there is a major limitation in that we are highly dependent on people reporting these deaths to us. So we do think that there's a little bit of undercounting happening because of underreporting. The second piece to that, the second pillar to our project is hospital data collection. So every 6 months, we do place a request with the two major hospital networks in the city to supply us with the information about the people who are either listed as NFA or living in a shelter. The major limitation there is people actually have to be coded in the EMR as being an NFA or staying at one of the shelters in Hamilton. And a lot of the time people might use a family address, or they might use an address where they're couch surfing, etc. So there's a little bit of undercounting happening here. We release the data every 6 months, and we just had our second release last week. So here's what we've been finding. We've learned in the last 12 months about 29 deaths in the city of Hamilton among people experiencing homelessness. Like I said, we unfortunately think that that is an underestimate because of the limitations that I listed. But among the people we did learn about, the average age of death was 38, which is really quite alarming. This one, I mean, it is a little bit more of a normal distribution, but it's centered around people in their 30s dying. Now, when you compare that to the life expectancy in Hamilton based on census data, which is 81.3, I mean, these people are living less than half of what is expected of their housed peers. Other things that we know about people who are dying. So we are predominantly learning about deaths amongst male people experiencing homelessness, over 3/4. And then we are learning about half of the deaths are in people who are chronically homeless, so greater than 12 months. And if you'll recall, I showed a graph earlier on in the presentation that the majority of people we know about who are experiencing homelessness have been homeless for less than 6 months. So really that chronic homelessness seems to be a risk factor, at least in our city. We are predominantly learning about white people who are dying, but there is also a fairly large proportion of Indigenous people experiencing homelessness who are dying. And there's a little bit of a split between whether they are unsheltered or sleeping rough or staying in a homeless shelter. So this, unfortunately, is a little bit blurry. It is directly pulled from Excel, but these are just some of the comorbidities that we're learning about in the people who have died. We're really seeing an overrepresentation in mental illness and substance use disorders. So over half of the people who we learned about having died, so that's 15, are experiencing a mental illness separate from a substance use disorder. So there's really a huge intersection there, and we'll speak to that later in the presentation as well. And then we are seeing a variety of substance use disorders in this population as well. This is also, I think, a really important graph for us to think about as healthcare providers and people who work in hospitals in particular. So 8 of the 29 individuals were seen in an emergency department in the month before their death, and 2 of them were discharged from hospital. So that speaks to the fact that there potentially on a healthcare level was an opportunity to intervene. There's also 5 people who we learned about who were released from a correctional facility or from usually the Barton Street Jail in the 30 days prior to their death, and then 2 people who were service restricted from a shelter, so turned away from a shelter in the month before their death. And finally, how are people dying? So I'll speak first to this little pie chart. So there's a bit of a 3-way split between whether people are dying in shelter, in the streets, or in the hospital. And so that means that about 2/3 of people are dying in a shelter or on the street. And overwhelmingly, these deaths are due to overdose. And this reflects very similarly to the Toronto data. 16 of the deaths that we learned about, 16 of the deaths that we learned about were in people who died of overdose. So this does reflect some of the data that we've seen in prior studies. There have been studies out of Boston, out of Philadelphia, that show that it is the leading cause of death in people experiencing homelessness, increasingly because of polysubstance overdose and synthetic opioid. I think at this point, it's important that we take a step back and say, and look at really what is a bidirectional relationship between homelessness and potentially drug overdose. So homelessness in and of itself can lead to higher risk drug use. When both drug use and homelessness are criminalized, so people on the streets are often forced to move along from encampments or from where they're staying on a street corner, that can lead to more rushed drug use and higher risk drug use, or more hidden drug use, potentially in a location where it's more difficult to find and potentially resuscitate someone. Because these people are frequently displaced, there's also a difficulty in connecting them to resources or to a community that can help them with their drug use or with lowering the risk of their drug use. So all of these things contribute to a 12-fold higher rate of overdose-related mortality, and this was out of a study in Massachusetts. So when we're thinking about interventions, we have to concurrently think about drug use and harm reduction strategies for the drug use and homelessness. There was just a report published this past June on the Government of Canada website about showing pretty similar things. So people experiencing homelessness are overrepresented among those who died of substance-related acute toxicity. And if we look at these numbers here at the bottom, so of the people who died of drug overdose, about 8% of them were experiencing homelessness at the time of their death, where only about 0.6% of Canadians experienced homelessness in that same year. Now, I also wanted to point out this key finding that they highlighted, because it pretty well reflects our data, that 1 in 10 people who died were released from a correctional or healthcare institution in the month before their death, and 1/4 of the acute toxicity events leading to their deaths happened in an outdoor setting. So I'll hand it over to Tina to talk about overdose.
Thank you, Ina. I want to provide you with an overview of interventions that are being shown to be effective in overdoses. This warrants a talk in itself, so I just want to give you an overview. So here's the data from Health Canada showing the death and hospitalization from 2016 to 2022. As you can see, 30,000 patients had opioid-related death and 32,000 had hospitalization. And shown on the top right is a trend in mortality and hospitalizations over time. Alarmingly, we see that with COVID pandemic, there's significant uptick in both. So you can see that the death almost doubled from 8,000 to 15,000, while hospitalization also saw a significant increase. So with that, the government has come up with a drug policy. I have these 4 pillars. I am only highlighting a select few things in the drug policy. They're between the federal and provincial government. They're contributing $300 million to access to treatment. That includes support for opioid agonist therapies, which we'll discuss shortly. There is increase in harm reduction in the approved supervised injection or consumption site. There's increase in access to naloxone kits and increase in support for the Good Samaritan Drug Overdose Act, which protect individuals from having drugs while seeking help for the overdose. There's increasing enforcement by increasing drug analysis service to identify toxic drug supply. And there's increase in various initiatives to raise awareness and address stigma regarding drug overdoses. So supervised injection site is really a harm reduction strategy whereby people who inject drugs can be supervised during the process, have access to clean needle supply, and have access to often treatment for drug use disorder. It is truly a global initiative, and here's a timeline of its history. It first opened up in 1986 in Switzerland, followed by various other sites in Europe. Outside of Europe, there weren't many other sites until early 2000s when one opened up in Sydney, and our very own site opened in Vancouver in 2003. And within Hamilton, our first temporary SIS opened in 2018. Now, switching gear to Insight, the Vancouver experience. As I mentioned, it is a harm reduction model, and showing the picture are the various injections, little cubicles, and it also has significant support in terms of allied health. So you have access to nurses, mental health workers, social workers. There is on-site withdrawal management services just above the Insight where people can detox, and there's connection to housing, other services. This is particularly important because 20% of their clients were experiencing homelessness at the time of intake. So what do the data show? So looking at the stats from Insight, in 2019 alone, they had over 170,000 visits from 5,000 individuals. They had 300 injection room visits per day with 3,000 clinical treatment interventions and over 1,300 overdose interventions. The literature has been overwhelmingly supportive of Insight as well, showing 35% reduction in overdose around the site, not just within the site. And 23% of these clients actually stopped injecting drugs after they received the appropriate care and resources. Modeling showed that about 5 to 35 new HIV infections are prevented per year, and 2 to 12 lethal overdoses are prevented per year from Insight alone. However, it has been quite difficult to keep Insight open. So it initially was a 3-year pilot project under the Liberal government, and after the government changed hands, it met a lot of challenges. It required 3 court decisions between the BC Supreme Court and the Federal Supreme Court in order to have it finally kept open and receive ongoing funding. So switching gear to Hamilton, our first SIS opened in 2018 after a needs assessment was published in 2017. And I just want to point out some of the stats in that report. Of the 70 respondents who reported injecting in public, 43% of them did so due to homelessness. And shown on the right is the monthly data from our SIS in Hamilton, which is called Consumption Treatment Service. And on the bottom right, you can see that within 1 month, you have over 500 consumption visits. And on the bottom left, you can see that within August of 2022, there's 6 overdoses and 5 of them require naloxone treatment. And these are 5 people who might have been adversely affected by their overdose, and then who are now who were treated appropriately and in a timely manner. So it's been an uphill battle for SIS, even though the literature showed that SIS is effective. So the systematic review from Levingood in 2021 of 22 studies showed that there is improvement in harm reduction, increase in treatment for addiction, improvement in injection behaviors, and reduction overdose morbidity and mortality. One of the public concern is about worsening public order, and multiple systematic review show that there is decrease in the number of public injection, decrease in the publicly discarded syringes and injection-related litter from having SIS, and there is no increase or decrease in crime rate in the surrounding area. So why is so hesitant? Despite literature showing that even brief targeted education for the public is effective in changing public attitudes, there is ongoing hesitation from policymakers who often leverage scientific uncertainty against the establishment of SIS, even though I just showed you from the previous slides that it is effective and it does not worsen public order. But the future is bright. Shown here is a map of all the overdose prevention sites and SIS within Canada. The green plus signs are approved SIS sites, and the blue are overdose prevention sites currently in operation. These are usually a sort of more bare bone version of an SIS, and there are multiple other sites that are currently pending approval. So perhaps it's finally gaining momentum. To date, federal government have provided exemption for 39 SIS, and as of July 2022, these SIS have been visited more than 3.7 million times, with over 41,000 overdoses treated without a single death, and over 200,000 referrals to health and social services. Now, switching gear a little bit to the opioid agonist treatment, which is another intervention within the drug policy. What are opioid agonist treatments? These are pharmaceutical grade opioids, including diacetylmorphine, which is heroin, hydromorphone, which is Dilaudid, and other forms of long-acting morphine. They come in oral, smokable, or injectable form. Why are these being used, and what is the indication? These are for people with treatment refractory opioid use disorder, meaning that they have tried methadone, they have tried Suboxone, but still have severe opioid use disorder. Now, there have been lots of data in the literature showing its effectiveness. So this is a randomized controlled trial called Naomi that was published in NEJM, where they looked at people with fairly severe opioid use disorder and randomized them to either 12 months of injectable diacetylmorphine, which is heroin, versus 12 months of oral methadone, which is your traditional treatment for opioid use disorder. And they looked at rates of retention in addiction treatment, the drug-free status, and reduction in illicit drug use or other illegal activity. They recruited 251 patients, and these are mostly people from Vancouver and Montreal. Of note, 88% of participants from Vancouver had unstable housing, consistent with what we already know about this population. And they found that in the intervention group, which is the injectable heroin, there is higher rate of retention in addiction service and more reduction in the rates of illicit drug use or other illicit activities. Next slide. Building on the success of Naomi, there's a second randomized controlled trial published in JAMA looking at injectable hydromorphone versus injectable heroin, basically seeing are the opioid agonist treatments all equally effective. And similarly, they look at people with a fairly severe opioid use disorder and randomized to 6 months of the two injectables. The outcomes they looked at is the rate of street heroin use, essentially looking at how effective these medications are preventing users from using street sources. And they randomized, next slide, 200 participants. And as you can see, these are people who have been long-term opioid use, have long-term opioid use disorder, and they demonstrated non-inferiority in the injectable hydromorphone. Of note, both groups had high treatment retention, consistent with what we knew from the prior trial. Next slide. So we know that opioid agonist treatments work in at least randomized controlled trials. How are they in real life? So shown here is the first SOS program in Canada, Safer Opioid Supply, just down the street in London, where they had comprehensive services with primary care and management of infection with HIV and HCV, counseling support, housing support, social services, in addition to the Safer Opioid Supply. And their clients are fairly complex in terms of medical and social needs. 62% of them were experiencing homelessness at the time of intake, and all of them had experienced homelessness at some point in their life. And there's very high baseline rate of HIV and HCV. So how effective are they? So fresh off the press is a study publishing CMAG looking at people in the program before and after enrollment compared to people who are not in the program. And they looked at ED visits, hospital admissions, admissions for infection, and healthcare causes. And they found, next slide, they found that in all of the outcomes, they're being decreased after people were enrolled in the program. So rated ED visits decreased by 31%, inpatient hospital admission decreased by 50%, and there's there's more than 50% decrease in healthcare costs not related to primary care outpatient medication. Of note, there is cost associated with the opioid agonist treatment, but the overall healthcare saving is still positive. And these changes were not observed among the MASH cohort. So we also know that combining these interventions are more effective. This study looked at the whole slew of interventions in Vancouver and the outcome between 2016 and 2017. So just within a year and a half, they found over 3,000 deaths were averted, and half of them are from the take-home naloxone kit. And opioid prevention overdose prevention services prevented about 200 deaths and almost 600 of them from opioid agonist therapy. Next slide. So why is that important to have combined intervention? Shown here is the projection of death from opioid overdose over time with 4 different scenarios. The blue line, sorry, the dark blue line is if the level of fentanyl increases, the green is we continue status quo, and only one of the 4 actually shows a decrease, and that is in the scenario if we increase the amount of prevention services that we have to prevent more deaths while the fentanyl supply remains the same. So in addition to overdoses and opioid use disorder, patients who experience homelessness also have a lot of other comorbidities. They suffer from injuries and MSKs due to lack of shelter. They suffer from chronic cardiovascular respiratory diseases, which are often undertreated, and they suffer from complications of infectious diseases such as HIV and hepatitis C. And most importantly, there's a significant overlap between mental health disorder and experiencing homelessness. And with that, I'll hand over to Dr. Jay.
Thanks so much, Tina. Yeah, so how about if we take a step back and look at the big picture, looking at the midstream and upstream interventions. As discussed earlier, homelessness is both a consequence of and a contributor to psychosocial issues. How can we break this cycle? This interesting initiative out of Montreal highlights some important principles when addressing mental health issues in individuals experiencing homelessness. Next slide, please. First of all, it was an interdisciplinary study involving hospital leads, clinicians, shelter reps, social work, housing resources individuals, and experts in supervised injection. It included individuals, adolescents and adults up to the age of 30. And the important principles were, number 1, need assessment. So what was the perception of mental health resource access amongst the youth? What were the factors hindering and facilitating access? And then they identified the issues early through broad presence in shelters and having youth-friendly identification sessions such as yoga, art session. Then there was a very rapid access to initial evaluation within 72 hours, and they developed a comprehensive and timely care. So not just medical and psychological, but also educational, employment, housing, financial, and so on, all of them free. The care was continuous. So same group of healthcare providers accompanied individuals through transition to adulthood. And the youth were actually participated as ambassadors in the program, and their feedback was extremely valuable, leading to many changes in the program. Finally, there was reports of improved not just health, but also housing at the end of the initiative. Next slide, please. We talked about initiatives around overdose and mental health. How about further upstream, particularly housing? Next slide. This systematic review looked at 84 studies published between 2004 and 2009, examining the effectiveness of interventions aimed to improve health of individuals experiencing homelessness. And what it found was provision of housing upon hospital discharge was effective in decreasing substance use for those with substance use disorders, reducing relapse from substance abstinence, improved psychiatric outcomes, and overall health outcomes in those with HIV. Next slide, please. Just to zoom in on 2 of these studies briefly. Number 1, upstream intervention looking at housing first. And by housing first, I mean immediate access to permanent housing with no readiness requirements. So no need for sobriety, for example. Next slide, please. So this was a study looking at 134 individuals with no fixed address and alcohol use disorder. And through Housing First, they actually saw that approximately 2% decrease per month in daily drinking while participants were housed. Next slide, please. A similar study, a randomized control trial looking at rental assistance. Next slide. Enrolled 644 individuals with HIV experiencing homelessness. And it found that immediate rental assistance with a case manager compared to customary housing services led to improvement in self-reported physical health, depression and perceived stress, and enhanced healthcare utilization. I'll pass it on to Ina.
So we'll just speak very briefly to some of these fantastic interventions that Tina and Mo have talked about that are currently happening in Hamilton. So with regards to harm reduction, I think Tina mentioned the consumption and treatment services that is at the urban core. So that is a supervised injection site that also provides harm reduction supplies and connection to resources. There's actually what's called a safer use drug space that recently opened at Carol Ann's place from the YWCA. So that's not a supervised injection site that's open to kind of everybody. It's specifically for those accessing Carol Ann's place or the YWCA, and it's for women and non-binary people, and it operates overnight. And then there is the Support and Safer Supply Program, or SAS, which Dr. O'Shea is a part of, and so is Dr. Claire Bodkin, who was a part of the study that I had mentioned before. And they are providing prescription opioids like Tina spoke about, and currently serving 40 people in the city of Hamilton. Now, in terms of moving forward, there needs to be a consideration for services linked with the shelters. So like the data that I presented before that showed that there was a lot of mortality happening in shelter or on the streets, really meeting people where they're at and being able to provide those harm reduction services will be vital moving forward. And of course, meaningfully engaging people who have lived experience with homelessness from the very initiation of the programs so that they can speak to how those programs should be designed to work best. Now, in terms of going upstream, Mo spoke a little bit to Housing First and really the value of housing people with homelessness. Hamilton-based affordable and supportive housing model is Indwell, where they have 24-hour on-call support for residents, and they engage their residents in supports, including social work, nursing, and addiction support.
I'll talk about this really good initiative that's actually our very own internal medicine residents developed last year. And essentially, this is a Hamilton Social Medicine Network looking at various referral resources that we can use upon discharge or in clinic, and specifically include sections on housing, shelter, and food services, as well as mobile care, like HamSmart. And the referral process is actually there. And I put the QR code here in case you're interested. Thanks very much. And so to summarize then, consideration of contributors to and consequences of homelessness is important when addressing it. There is a lower age of mortality amongst people experiencing homelessness than in the general population. Overdose is the biggest killer, but multimorbidity is also prevalent. And it's important to consider upstream interventions, such as housing, and downstream interventions such as harm reduction to reduce morbidity and mortality, and they're both evidence-based.
That is all for our slides. I'll just click through the references so that they're available later on, but we are very happy to take questions.
Thank you very much for this comprehensive and stimulating, actually, presentation of a difficult healthcare issue that we deal with daily in Hamilton, with lots of opportunities. I can see that. For those who are interested in asking questions or comments, please put your question in the Q&A. You can write a comment in the chat if you want to. And if you would like to have your question in person, please raise your hand, and I'll bring you in to speak up. I'm just going to take my shot at first question, if that's okay with you. Great data, good way forward, a lot to be done. Can you comment on that situation? I mean, I know the focus here is homelessness, but we have an intersection between hospitalization, homelessness, addiction, and what should be done or need to be done, where the gaps are in our healthcare system in terms of hospital systems, rather than just the social and the community part. Where are the gaps in our hospitals right now in terms of providing care for this needy population, deserving population?
So I'm happy to kind of take a shot at it. I think, Mo, you might have some things to add as well based on the studies you talked about in the beginning. So just in terms of when we are providing care for people experiencing homelessness or people experiencing addiction, whether or not they're experiencing homelessness in hospital, there sometimes are a lot of barriers just in terms of people, the barriers that people experience in terms of stigma from healthcare providers and stigma regarding their drug use. So we don't speak to this extensively in our talk, but things that support people actually remaining hospitalized and remaining in treatment for whatever they are hospitalized for can include just all of us approaching these people with an open mind, more lenient coming and going policies if people do want to use drugs while they are hospitalized, and early involvement of the addictions team to see if there's opioid agonist therapies or something that can support them while they are hospitalized in terms of their addiction. I don't know if anyone has anything to add.
Absolutely. No, totally agree. I think that's that speaks to the importance of the kind of stigma. I also add that so two things. One is from a systemic perspective. I think individuals with homelessness, when they get admitted upon discharge, a lot of times although we know that they have no place, no kind of permanent place to stay a lot of times, but despite that, because of the administrative burden and the pressure because of hospital beds, sometimes we kind of end up discharging to no permanent place. And that's an issue that certainly needs to be addressed, and it is a barrier to health. So we know if they go back to where to the streets, then chances are they get the same medical issue again because of the reasons discussed. So that's food for thought. And the second thing is the initiative I talked about from Montreal. I think one interesting thing about it was he actually looked at the clients, so the individuals with experiencing homelessness, and they actually took their kind of facilitated access to healthcare for them. So the feedback was they needed to be admitted to the hospital immediately. They didn't want to go through Emerge. That was a barrier for them. And they actually did it. So direct admission, come through. You don't need to actually be seen by an Emerge doctor. If the internist knows you, then you can actually be admitted. And the second one is if maybe they want to wear their own clothes in the hospital, for example. So kind of listening to them and kind of reducing the barriers through specifically kind of making a committee from individuals experiencing homelessness and kind of seeing what they want to reduce those barriers.
Great points. Thank you very much. See, Dr. Darsami has his hand up, so I'll bring in Panji to ask his question in person.
Thank you, Khalid, and thanks to our residents that presented an excellent talk. I think there are lots of concerns that we all have about housing. I'm not sure if you all can hear me.
You're
Hello?
good. You're good, Panji. Keep going.
It's like sort of mind-boggling to think about how much is being spent in patients admitted to hospital merely because of no housing or inadequate housing. I mean, we have patients that have been admitted for several months to over a year, or almost 2 years in a hospital, at approximately $2,000 a day. It's really mind-boggling to think about how much we're spending, and yet there's no as far as I'm concerned, there's no commitment from the government to provide some form of either formal or informal housing where there's adequate running water, electricity, and a place to sleep. And I mean, there's just no commitment that I see. I mean, the government is providing, or the ministry is providing, access to patients that can go for, injection sites and so forth. And then maybe some food supplies, but in large part, it doesn't seem that the government is actually doing much about providing proper housing with the basics in life, like such as, water, running water, electricity, etc. So do we have any information about this, or is there any sort of approach to the government to indicate how much we're spending just on hospitalization for these patients that don't have homes?
Yeah, I think you touched on a super important question, Dr. Doraisamy. And I think some of the data that Mo went through about housing first and about really how much you can, I mean, I hate to reduce this down to dollars, but unfortunately governments think that way. But there is a bunch to be saved in terms of healthcare dollars with just housing people, that pure upstream intervention. And in terms of, I'm not even going to get into, it saves lives and it improves health. I'm going to put a quick plug that housing is a municipal issue and there is a municipal election coming up. So we all have the power right now to hold our candidates accountable. And then once people are elected, to hold our elected officials accountable. Because I entirely agree with you, Dr. Doraisamy. We have this is what we see anecdotally and we see it every day. And then there's hard evidence that I agree that the government should be following, that housing people is the most important thing we can do.
Yeah, absolutely. It's such an important topic. I'll just give an example of from one of the papers that we read. So this is one patient, and he had 27 admissions to the 27 presentations to the ED, and his total cost for 51 ED presentations over 27 months period, January 2015 to March 2017, was $33,456. And the cost of the 28 inpatient admissions amounted to $299,460. In total, this represents a cost to the health system of almost $333,000 or $12,333 per month over 27-month period. And so this is US dollars.
Yeah, clearly a failure in the system. So thank you, Ina, for putting the plug into the municipality election coming up. There's a question in the Q&A, and I know that's maybe a lot to go back to, but the question is around the level of evidence and which of the studies you presented are actually randomized and which are observational. I'll just say maybe if you can highlight any randomized controlled trials or the importance of that, whether it's that the important way to look at it, maybe observational are adequate enough in this evidence level.
I think that question was raised to Mo, when you were going through the housing first study, but I can also speak to my part. The systematic review that I had, that I quoted, I looked through the type of study because of the nature of the study, which is usually on supervised injection site. There's no way to randomize a lot. There is no RCT, but of at least one of the systematic review, at least half of them were prospective trials. So as good evidence that they can be in this scenario. And I'll hand over to Mo to talk about his part.
Yeah, absolutely. For my part, I think what I found interesting, all three of us, was the studies actually looking at housing. A lot of them were randomized controlled trial. And so, I think, the evidence becomes stronger with RCTs. And for example, the study talked about housing first, that was randomized control trial. The study I talked about with rental assistance and individuals with HIV, that was randomized control. And the systematic review that, I described, looking at housing and the impact on on health in general, mental health disorders and substance use disorders and HIV. That the systematic review of this one, that also included almost, most of the studies there were randomized control trial, which I think is actually impressive.
That's great. Thank you for those comments. I don't see any more question. I have a question actually about the utilization of that online platform that you put together for the internal medicine, social medicine group, and how's the access to this? Have you looked at utilization? How can we make it more popular and used? And our social workers and other healthcare providers in hospital system, we spend a lot of the time in the hospital. So I'm going to go back to the hospital. Are you utilizing it? Or in the clinics? Are we going and looking at this? I will get the cue card myself, but what's your experience been?
Yeah, we're definitely trying to increase utilization, hence the shameless plug in here. But there is, a whole bunch of us got together and put together a lot of resources that are available here. So we share it in the internal medicine newsletter every month, but highly recommend looking into the clinic referrals section here. And then in terms of like the education section also has a lot of really good resources if you want to learn about any specific marginalized population. And then there's a social medicine rotation section as well for people who are interested in going through the rotation who are internal medicine residents. So highly recommend checking it out.
Really. Dr. Azam, if you'd be open to including one of the HHSC emails that goes to the staff here, would be delighted.
Absolutely, it's going to be in the next newsletter. This is not shameless plug, but actually this is an important resource that we need to make sure it's available to everyone. Before we close, I'm wondering, Tim, I don't want to put you on the spot, but any final comments? This wonderful rounds today that is, done with that very, very intelligent and capable residents.
I couldn't say it better than that, I don't think. I mean, I think that's my final thoughts. That was a great rounds. And I think the questions were answered extremely well. So yeah, I don't think I can add anything on top of what's already been said, except for thank you very much to all three of you. That was excellent.
I think, Doctor, we have a few minutes left, and I see Dr. Tolman has her hand up, so I'm going to bring in Marianne to speak.
So I've often wondered in this population of individuals, if they were able to secure some sort of work that they found rewarding, if that might go a long way for their sort of overall mental health. Have there been any projects looking at securing opportunities for jobs?
So there's a study by Milby and all. I think they published in 1998, and then they published again in 2004, 2000, and they kind of around the same type of thinking of what is the role of employment in individuals. Their study, I didn't look at the 1998 in detail, but the one in 2004 is an RCT. It actually looks at so it kind of compares the effectiveness of behavioral treatment plus kind of housing and work therapy compared to behavioral therapy alone. So they kind of introduced two interventions in addition to behavioral therapy. That was employment and housing, and then they found the substance use disorder significantly improved as a result of that study. So I think so Milby is as an author that actually been looking at the employment and really good of it. Effects have actually been seen.
And I just carrying on with that, the social workers and the workers that are involved locally, do they have any role in helping to secure not employment so that they can get a job and work, but really so that they're doing something that they might find rewarding for their overall well-being?
I would imagine so. And so also in speaking to the overall picture. I understand that you're having employment will be helpful for finding for securing housing, but there are also barriers to it in addition to whether you have employment or not. As we, I think, mentioned multiple times in your presentation, it's sort of a cycle that we're trying to break. So opioid use and homelessness contribute to overuse, mental health and homelessness. It's bi-directional. If it's helpful at all in some of the studies that I mentioned, where they were, when they address the opioid use disorders, such as providing supervised injection, providing safer opioid supply, and in these population, they were able to seek for treatment for the opioid use disorder. They were connected to social services, and the outcomes are good. That some of these found housing long term, some of these found employment long term, some of them are actually stopped injecting drugs. So I don't think it's one intervention and whether that can change their outcome. It's sort of like they all kind of happen at once, and it has to be a multi-pronged approach.
I know we're over time, but just very quickly, Marianne, not in a study way, but just in terms of anecdote with our group with HamSmart, we work closely with Keeping Six, and Keeping Six has gotten the ability now to do official training for peer support work. And so we've been able to help people get that training, and then through that get paid employment with Keeping Six or other organizations doing peer support work. And I think, just like you sort of alluded to anecdotally, the benefits, both just in terms of, I mean, the financial benefits are great because people are all struggling in terms of just making ends meet week to week and month to month, but also just the community that creates of people taking ownership of the organization, feeling like they're really a valued part of it, and being present with a community of people week after week, I think has been quite beneficial for many people, for sure.
Fantastic. Thank you very much for those comments. I think we're at time. Tina, Ina, and Mo, thank you very much for this great, important rounds. Tim, thank you for supervising, and I wish everyone a great rest of the day. Thank you for joining today.